out. If he had had a serious vascular injury, he wouldn't have made it to the hospital. I'm a little puzzled by the story about him having a Glasgow coma scale at 7, with what looks like a laceration to the abdominal wall and the left lateral part of the abdomen, probably with no major vascular injury. Assuming that that's a picture when the patient arrived to you, the abdomen's not distended. But I agree with Dr. Hochman. In the trauma bay, some IVs, get some set up for some blood if you need it, and do your full evaluation, assuming that he was stable. We don't have the vital signs at arrival, but I would expect that he would be relatively stable, or maybe needing some additional fluid resuscitation, to which he would respond, and then go to the OR to take care of the eviscerated bowel.
Perfect.
Dr. Menegozzo?
But Dr. Intl, he's received 4.5 liters of fluid.
Yeah.
Yeah.
No,
It's
I understand. I understand, and we'll see what they find. Just looking at the 4.5 liters of fluid, and then depending on what his vital signs are after that, I would expect that he would be stable. That if 90-minute transport, it's outside of the golden hour. But either way, I mean, you could take him to there wouldn't be much. These patients, they come to when they arrive, then they get very quickly taken to the OR, and there's very little difference between the two. But between the two choices, even as Dr. Hochman said, and I agree that very quickly he would go to the operating room. But this patient, I would expect that he would have those injuries to the bowel, and he probably needs some bowel resection. And had he lacerated his aorta, then he wouldn't have made it. He wouldn't have survived 90 minutes without intervention. But anyway,
Yeah.
we'll see what happens.
It's perfect. Well, just to get some of the polling. So most of the people who answered.
Dr. Menegozzo,
Yeah.
just please. I think we missed the recording since the beginning. So just to have this on the website, can you summarize the case again, please?
Sure, no problem.
So let's start moving on for now, because I think we missed the beginning of the recording. Thank you.
No problem. So just a quick reminder of the case then. So it's a 20-year-old male patient. He had an abdominal laceration by a mower blade. He was tachycardic, 115 BPMs and 90 of SBP. He had a GCS of 7. That was the information that we got from the pre-hospital team. 4.5 liters of ringer lactate on the transport, and it took 90 minutes to get there. And it took a lot of time because the patient was in a difficult area for the guys of the EMS to get to the patient. So they got to the patient, they started him on fluids, and they took him back to the hospital. And they took him there by helicopter. And it just showed a video so everyone can understand what's happening. He was using this equipment. This is not the actual patient. This is a video from YouTube. And you can see that the blades from this equipment, one of the blades got out of the equipment and struck him in the abdomen. That's why he was getting into the hospital. And this is the set of blades that are available in such equipments. And I'm going to show you what happened with this patient. So we were just talking about where would you take this patient for initial assessments. Most of the respondents and also the panelists, they were favorable to do it in the trauma bay instead of going directly to the operating room. And that's what we're going to discuss. So actually, we took this path. The patient went directly to the OR. I was not directly involved in the first assessment of this patient and the first treatments. And this patient was initially assessed in the OR. And what they saw there is that he had bilateral normal breath sounds. His skin was cold and pale with a capillary filling of 4 seconds. There was the intestinal evisceration that I showed you guys in the first slide. No external active bleeding, and he had also hematuria. He was intubated. There were no other visible injuries. he had a temperature of 34.5 Celsius, and this is the initial gas, arterial gas of the patient. So he had a lactate of 33 and a base deficit of 7.1. So this is just the picture of the hematuria for you guys to see that there was blood coming from the urine catheter. And now what I wanted to ask now before moving on to the rest of the case is just specifically regarding measures that you can take to minimize the effects of hypothermia. So I just wanted to ask you the panelists, do you guys have any measures that you can start really early? And what do you guys use? Do you guys use warm fluids? Do you guys use sheets? What do you guys use to make sure the patient's not getting hypothermia? Because he was in a difficult area. There was some water there, some rainy days, so that's a big problem for this patient.
Thank you, Doctor. Dr. Intl, would you like to share your experience with us?
Yes, well, we would raise the temperature of the room, and then we have bear hugger devices to cover any areas that we could, assuming that there were no injuries to the chest. You didn't operate in the chest. We would cover the arms and then the upper torso, and then we'd warm the fluids. We have the Belmont infuser that can infuse rapidly and also warm to all the fluids to 38 degrees. Very quickly, so we would do all of those things to minimize the effects of the delay.
Perfect.
Thank you, Dr. Anka. Dr. Cassin, any comment?
Along with all the things Dr. Intl said, the single most heat loss in a patient like this is from the head. I would put one of those silver cap on to make sure that he's not losing heat from the head as well. Thank you.
Thank you, Dr. Cassin. Dr. Hockman, any comments?
Yeah, it would be essentially warm fluids. That's the only thing that is really effective in these patients, and remove everything that is wet from the patient. We always heat the room. Anesthesia always plays a bear hugger, but those two methods are really not very efficient. The air has a very low specific calorie. They don't. That's the reason we can put a hand in the oven and retrieve something without burning ourselves, but we cannot put it in boiling water. The water has a specific heat that is very high, so the temperature change can happen very quickly. So if the patient has cold water, is wet, it will lose more temperature. So he needs to be removed from the cold, damp clothes, dry him up, cover him. And usually by then they are exhausted, so they have a very hard time rewarming themselves. There have been many studies proving this. So the most effective way is to administer warm fluids. In patients that are severely hypothermic will be some type of extracorporeal circulation, which nowadays will be probably be ECMO to warm the patient up. I have operated in patients this cold. Is kind of scary because the threshold for ventricular fibrillation is very close. Sometimes you have no option. So we will do all those things, but the most effective one will be the IV fluids, the most accessible ones. Thank you.
Thank
Perfect.
you. Dr. Carlos, your turn. Dr. Menegozzo, can you hear me?
Fluids, hot fluids, so bear hugger devices, warm fluids. So most of the guys watching I'm sorry, let me just take this out. So everyone is actually trying to start him on IV fluids and maybe go from there and have this for the patients. So the next thing that I wanted to ask you guys and this is also going on our, let me just take this out. I don't know how to, oh, okay. So also going in our poll. Now I wanted to ask you about transfusion. And what would you do with this patient? Would you trigger a massive transfusion protocol in your institution with this patient? So just as a reminder, he was tachycardic. He had a SBP of 90, and he had a base deficit of 7. So would this be enough? And of course, he had a penetrating injury. So would this be enough for you guys to start a massive transfusion protocol? Yes or no? And if yes, what ratio would you guys use in your institutions?
Dr. Kassim?
It is not as simple as yes or no, because you have to look at the precedent event that took place. He has received 4.5 liters of fluid, and in my opinion, that is 1 liter too many. So now you have him in the operating room. He probably requires quite a lot of blood or blood component therapy rather than IV fluid in the form of crystalloid. But having 4.5 liter of fluid on board, if you start transfusing enormous amount of blood, you're going to put him into a detrimental situation of overload, congestive heart failure. So you need to kind of balance it out. You know, you may benefit even to have a central line or something like that, or some other modality that you may have in your hospital to look at the volume status and then be judicious in the use of the blood and the blood component therapy he so much needs. Because fluid alone is not going to raise his systolic blood pressure any more than what you've already done. You know, for every liter or every 10 cc of IV fluid you give, only one will stay in the intravascular compartment. The rest will all diffuse out and give rise to accompanying respiratory problems later on. So be aware of all that. And I think you need to be judicious in the use of volume. And it maybe you want to do a central line to get some idea where you're going from there. That's my opinion. Thank you.
Thank you, Dr. Kassim. Dr. Hockman, any comment?
Yeah, I agree with Dr. Kassim. It's not a yes or no answer. Probably yes. He already received too much crystalloid according to ATLS. The patient, the elevated lactate, it could be also caused by the hypothermia. The liver does not process lactic acid when the temperature gets close to 34. So that may be why the lactic acid was elevated. Having said that, the only safe assumption that you can make in a patient like this is hypothermia. Hypovolemia. So this combined with the hypothermia, as Dr. Untras mentioned, using the Belmont rapid infuser or the level 1 rapid infuser or one of those that allows you to warm the blood products, I think probably that's the way to go. We try to go 1-to-1 to 1. It usually doesn't happen for us because the patients go to the trauma bay where we have 4 units of uncross match PRBCs. But if this patient will have gone straight to the OR, over there we receive what we call the trauma pack, which is 10 units of PRBCs, 10 of FFP, and 2 packs of platelets, which is they're essentially 6 and 6. So it will be probably more close to 1-to-1 to 2. But again, it's difficult to say without seeing the patient how hemodynamically unstable it was. It looked like the injury is deep enough if the kidney is affected, so he's probably bleeding. But that's all. Thank you.
Thanks.
Dr. Antrak? Any comments?
Yes, so, right, so about the labs, if I caught the numbers correctly, it looks like the hemoglobin was 13 on arrival at your hospital, is that right?
Yeah, it's right.
13, okay, and then the lactate, remind me what the normal is, so 33 is not elevated, is it?
For us, it's 14, the limit here.
Oh, 14, so it's a little more than twice elevated, and
Exactly.
pH 7.2, a little down, and the bicarb is down slightly. So so 13 after 4.5 liters of Ringer's lactate, and then presumably the other kidney, the right kidney, is functioning properly. A 23-year-old must have put out. It depends on how much urine did he produce. Was it only what was in the bag? It looked like maybe a liter or 1,500 mLs of bloody urine. So, but still, after all that fluid, and his hemoglobin is still 13. That's little unusual. That okay, is that it? But anyway, so I would, depending on his status on arrival, what were his vital signs? I don't think you mentioned the vital signs in the OR when he got there.
Yeah, it's this one. So he was. Oh yeah, I'm sorry. So he was still tachycardic. He had a SBP of 90 on the OR when he first got there, and he had a heart rate of 115.
150. Yeah, so that 90. That's if we're resuscitating a patient that was bleeding, we would stop there at a systolic blood pressure of 90, and he produced urine during the trip in. So I would have blood available here. If we're operating here, we don't have platelets, so we would use fresh frozen plasma and packed cells initially, and then call for either type specific fresh whole blood, or a low titer O fresh whole blood, depending on the situation. In his case, probably type specific type specific fresh whole blood would be adequate. We'd have enough time, and then just have him ready for induction of anesthesia, and then proceed with the laparotomy. He's already there, but I think his his condition is, after 90 minutes, to have that hemoglobin, 4.5 liters of fluid. It seems that he has some bleeding, and the blade apparently lacerated the left kidney, and he's got bloody urine, but how much he's actively bleeding, how voluminously he's bleeding, I don't know. But you can assess with your ultrasound in the OR to see how full the belly is with blood, and I'm sure you did that.
Perfect. Yeah. So they didn't do a fast the ultrasound exam there in the OR. Actually, they went straight to laparotomy after the initial resuscitation. So what we found during laparotomy. So I took a small part of the video so you can see that there's bleeding inside the belly, and they are trying to get the blade out. So what essentially happened is that the blade got into the abdomen, and it was they didn't see it beforehand because the bowel was eviscerated. So this is the blade that was inside the cavity. They are just freeing the tissues, and there was a massive colonic injury. So the transverse colon was essentially destroyed, grade 5 injury. He also had a kidney laceration, or the left kidney laceration, and also he had some small bowel lacerations. So I'm just going to show you the blade. And so this is the size of the blade, was a really big one inside the abdominal cavity. And what was there, so the blade got into the abdomen from this laceration and straight to the other side. And so there's some injury in the abdominal wall as well to the right side. And what we saw here is he had essentially a partial nephrectomy, traumatic partial nephrectomy of the inferior pole. So you can see here on the right side, there's the renal vein, the ureter. Also here you have the renal artery, and there was a inferior pole laceration of the kidney. And as I told you guys, also there was some small bowel injury, which was a grade 3. There was a serosal tear at the ligament of Treitz and a foot thickness laceration in 2 points distally from the Treitz ligaments. And also the large bowel injury that I just told you, and the kidney injury in the inferior left inferior pole. So considering all these injuries, how would you start? Would you think about doing a definitive repair approach? I mean, any form of repair, and I want to know and to hear your opinion especially in these 3 lesions. Or would you go for a damage control surgery, and what would you do in this situation? And that I'm just showing you also the blood gas analysis of this specific time during the surgery. So these are the other parameters that we have in these patients. So, and also, if you the people who's watching the clinical discussion, if you guys want to answer, just put just read this QR code and put PTS 22 in the room name. So feel free to comment on the approach, the intraoperative approach, and what would you do in repairing these situations.
Dr. Antrak, would you like to share your experience with us?
Yes. So the hemoglobin is 17. Did he get transfused at the outset?
Yeah, he did. I was going to
With
show
how
you
much?
this. He had 3 units of blood.
Of packed cells.
Yeah.
And that's it. Right. So, and that was after the incision or before the incision?
He was taking the first during the incision, and he was at this time he had took 2 units, and he was taking the third.
And the vital signs were what at this point?
Yeah, he was just tachycardic. He was 110 heart rate, but his systolic blood pressure was normalized.
To what? To what? 120 or higher?
It's no, it's 112.
Okay, and his temperature?
Normalized. It was 36.
36, so slightly hypothermic, and so you got 3 units and from 14. So basically, he had not really bled. Most of the bleeding, he'd bled from the blade, and the bleeding had mostly stopped. That was the blood that he initially lost. Right, and that you kind of expect it with these cases. So you can, in this case, I think it's probably okay to proceed because he's getting better. His pH is higher, and lactate, we don't have that, or you didn't have that at this point. Is that correct?
It's correct.
And he's making urine. As long as he continues to do okay, I would start just finish the removing the lower pole of the kidney, and then get control of the drainage. And if at any point he starts to show signs of deterioration, if he gets hypothermic, starts to ooze, then I would end the operation. But you can sort of proceed as if you're going to do definitive repair, and at any time you can convert to damage control surgery. You just stop the leakage, and resect the damaged colon, have the ends apart, repair the small bowel. Looks like that you can do that quickly, and just proceed if it continues to do well. And I would expect that would happen here.
Perfect. Thanks.
Dr. Hockman, any comment?
Looking at this, initially when you show the pictures, I thought that was the retractor. That blade was massive. Looking at this picture alone, I would go for damage control. What would I include in the damage control as definitive repair? Some of the things you have to address on the spot, but most of the other I would probably do damage control and get out, because this patient has very limited physiologic reserve, despite the fact that it's a little bit warmer now. But his physiologic reserve was probably exhausted by the hypothermia and the bleeding with it during the transport. I would see what is bleeding. I would imagine that the kidney was probably bleeding, and if it wasn't bleeding on there when resuscitated, will start bleeding. So normally we would go for an nephrectomy, but in this case, I think it's very reasonable to try to salvage the kidney. So amputate the lower pole, put a few vertical matrix sutures with a big chromic, like we'll use in the liver or something else, and save the kidney, resect whatever is destroyed from the colon, leave the colon stable. The only one that I might try to repair primarily is if the injury is very close to the ligament of Treitz, because having that staple and after that trying to repair, if it's any leak there, is really very difficult to handle. But I would just do the minimum necessary and get out and let the patient recover in the ICU for 24, 48 hours, and after that, go back. Thank you.
Hoffman.
Perfect. Thank
Dr.
you.
Kassim, would you like to share your experience? Dr. Kassim?
Okay. So there is a very famous lecture given by John Holcomb, who is the current, flavor for trauma surgery, and Dr. Holcomb is the chief of surgery at Houston Medical Center, Herman Medical Center, and he shows a very interesting picture in his lectures. I don't know whether you guys have seen it or not. He shows a picture of the brain, and when a brain is affected by drugs, the brain swells. And then he shows a picture of an open abdomen with a normal bowel, and then he shows a picture of and same abdomen with massive amount of fluid on board, and everything is swollen. You can't put everything back into the abdomen. You have to leave the wound open. So the lesson he is telling us is, don't give too much fluid. If you give too much fluid, you will have difficulty in closing the abdomen, at least in the beginning. So you have this patient who comes to the, you have taken, I suggested that you take the patient straight to the operating room. But in the operating room, in a trauma patient, you should always be careful when there is foreign body involved. You should get a plain film of the abdomen first, because you don't know where this foreign body may end up. It may be in some hidden area that you didn't realize there, and then you may have to go back and get it. So plain film of the abdomen before you do a laparotomy is a good idea. Keep that in mind. Second, once you have opened the abdomen, as a surgeon, you need to ask yourself a question. Am I going to finish this operation in a timely manner? In other words, within an hour or so? Or is the patient not stable, critical? Do I have to resort to damage control surgery? The way that I manage patients is I look at the patient and determine in my own mind, what am I capable of salvaging in this patient so I can get him back to the intensive care, alive in a stable condition. Looking at this case, I think most of the correction has been already done. Hemodynamically, he seems to be stable. So you have identified 1, 2, 3 lesions in the abdomen. I think I would just go ahead and repair it. The inferior pole of the kidney is a very simple thing to correct. Clamp across and use stitches, and you're done. And the bowel repairs are all very simple thing to do. And I'm hoping that you will be able to close the abdomen If not, then you may have to leave the abdomen open. I don't think I would go for damage control surgery in this particular case, knowing what I know from the parameters that you have put on the board. Thank you.
Thank you, Dr. Cassim.
Perfect.
Menegozzo?
Yeah, thank you very much for the comments. That's exactly what we thought about, and what we did, what the operating team did. They did primary repair of the serosal tear in the small bowel. They performed an enterectomy with anastomosis in the second and third lesions. They were really close to each other. The transverse colon was disrupted entirely, so they did a colectomy and a colostomy. And they did a partial nephrectomy because it was actually almost already made. So the inferior pole was resected, and they did the sutures in the remnants of the kidney. So these are the pictures after the anastomosis. Here is the anastomosis. Here are the tears that were sutured, and this is the final aspect of the partial nephrectomy, the inferior pole nephrectomy. And that was what they did in that time. They were able to close the abdomen. The patient was hemodynamically stable. He received a little bit of plasma, and also he received more ringer lactate during the surgery. And that's what we took about. We took from the operative notes from the anesthesia colleagues. He got a little bit. His condition was poor in the next day, actually, so he received more. The problem was probably resuscitation, and they thought about that in the time. They were not really concerned about compartment syndrome. He had his PIA was good, was not elevated. So they just managed him clinically, and he got better along the days. But he had a partial dehiscence of the midline incision. You can see that's a little bit small dehiscence over here in the most lower side of the incision. But here in the middle, they were concerned about having partial exposure of bowel contents. And so this patient, he actually went to the OR again. I'm just going to go over this in the interest of time, but I wanted to ask you guys if you would do the same thing. So he went to the operating room. There was a small opening in the facial opening, and so the people who operated him, they didn't want just to suture the lesions again, suture the midline incision and also the transverse incision that was made by the blade. They decided to put a mesh over the incisions to make sure it was not going to have another dehiscence. And I wanted to ask you guys if you would do the same. Would you do this with just a new facial suture, or would you put a mesh over it also? And what would you do in this situation? Would you guys feel that it was dangerous to put a mesh in this field after surgery, after colon injury? So what are your thoughts? So I don't know if Patricia is there. So Dr. Cassim,
I'm sorry.
Oh, I'm sorry.
I'm sorry. Dr. Cassim, any comment?
Quick answer. Don't put foreign bodies in a contaminated wound. That's what my teacher taught me, and that's what I teach my students. And I think I probably would do fascial mobilization and do everything I can to close the abdomen, and accepting that I might get ventral hernia. I think putting a foreign body in a wound like this, with this much contamination, delayed in repair, and transport time, and all that factors in, You have a wound that is full of bugs, and any type of foreign body you'll put in there is bound to give you headache afterwards. I don't like headaches, so I like to avoid it. Thank you.
Perfect. So Dr. Hoffman, do you want to comment?
Yes, or Dr. Hockman or Dr. Antrak, any comment, please?
In principle, I agree with Dr. Kasim. I wouldn't put anything in a contaminated field. This is very different than the approach that we normally take in patients like this. We routinely, in a case like this, we will leave the abdomen open, make sure that there is nothing else pending, maybe even scan the patient afterwards, and came back the next day or the day after and see what can be closed, and we would try to close primarily. If this patient needs something, we probably wouldn't put a mesh, we probably wouldn't do a component separation during the initial surgery. We would try to close primarily and get out, and if develop a hernia, we will deal with the hernia at a later time. This case is more complicated because you have essentially a T. So the two corners of that T, they have potential of being ischemic. So I would probably just get out with the minimum necessary and wait for the patient to recover, and after that fix that. You would need to go back anyway to reconstruct the colon. You might need to go back for other reasons in this patient. So we very unlikely that, but again, this is a regional variation. This is what we normally do. I'm not saying that what was done is wrong. I'm saying this is what we do, and there are always different approaches, and this is the beauty of this conference. We see people doing many different things and getting good results, and this is where we all learn. Thank you.
Thanks, Dr.
Dr. Menegozzo?
Yeah.
If I can just comment.
Oh, sure,
Okay.
Dr.
Of course, of course.
Yes, yeah, it looks like in the picture on the right that there is mesh there with a lot of sutures, but if I'm not mistaken, is that correct? That's what's there.
Exactly,
Yeah.
the picture on the right.
Yes, I agree with what Dr. Hockman and Dr. Kasim said, and you have to go back and operate again anyway. And I would open up the area where it looks like there's a dehiscence, leave it open, maybe put a wound vac there, and let it heal. If he gets a hernia, fine, and then deal with it later when you go back in electively, nice and clean. You can do a component separation and then reanastomose, and not have to put mesh in at all. But a couple of weeks ago, there was a presentation from the University of Miami where they put a biologic mesh in. I forget what you call that, but it's supposed to be appropriate for this situation, and it brings the biologic mesh. It brings macrophages, and it's supposed to work well. And they do that, and then they close primarily with these large retention sutures that they can tighten down. And whether that's that's one approach, but I don't know that that's any better than just letting them get a hernia and then closing it at the second operation. I would just as soon avoid getting a complication.
Yeah, perfect. Thank you very much. Yeah, they were really concerned about having another potential evisceration, so that's why they chose to put this mesh. So, but of course, it's very controversial, and that's why I brought this for discussion, because it's really interesting to have all of your opinions and different, as Dr. Hockman said, it's different approaches in different regions. So it's really interesting to see more of that. So this patient went well. So this is the final aspect of the surgical approach. This was the transverse incision that was caused by the blade. We extended it a little bit to make sure we were going to put the mesh and just close the incision the right way. And in the third postoperative period after this abdominal wall reconstruction, he had fever, and he underwent an abdominal CT. And you can see, I'm going to show you guys, this is the like a very late phase of the abdominal CT, and you will see that there's contrast extravasation to this collection here, very close to the inferior pole of the kidney. So there was some urine extravasation, and you will see this in a better view in the coronal plane. You can see that here is the collection extending also to the medial aspect of the abdomen, but really close to the inferior pole. There was some hemostatic over there also, so that's why you have maybe some gas also inside the fluid, and that was a big problem. So we got the urology guys on call, and they helped us figure out what to do. And the option was actually performing a double J. So they passed a double J, and they saw that there was stenotic segments of the urethra. We don't actually know what happened, why it was stenotic, but what they thought it was, the stenosis was causing higher pressure in the pelvis, and it blew out the calyces in the renal that was on the remnants of the kidney. So they put in a double J, and it seems it resolved the situation. He was discharged from the ICU 4 days later. But eventually he got a very difficult facial knot. I'm sorry, the skin dehiscence with no infection, but a really big dehiscence of the skin closure. So this patient underwent vacuum-assisted therapy in this region. When it was really well granulated, he was taken back to the OR for another closure, and there was no need for any help from plastic surgery or any forms of different scenarios. We just sutured again the abdominal wall, the abdominal skin in this region, and the patient went well. So after that, after the abdominal wall closure, he was discharged in the next day. And this is the last CT that the attendees, they took another CT scan in the outpatient clinic, and you can see that here's the left kidney, and you can see that the collection in the inferior part of the kidney is resolved. And in this CT scan, the patient had already taken out the double J. So he's doing fine now, and he's currently undergoing visits in the outpatient clinic with our staff. So I just wanted to share some learning points of this case, and I would be happy to have your final comments and also comments about the learning points that I'm going to address here. So again, I wanted to bring a very controversial case here, and I was really happy to see that most of the questions, some of the panelists were favorable to one answer, the others to another answer. So this was really interesting for me, and a very interesting learning experience. So what we learned and what we wanted to share with you and really stress here is that we believe that you should have institutional protocols to expedite bleeding control and also volume resuscitation. So we are currently reviewing our protocols also, and there are some interesting literature on that. You can I saw this study from 2021. They were discussing, this is a prospective study, that they were discussing the benefits of taking the patient directly to the operating room upon arrival in the hospital, and they have some criteria that they use to do it. And so one of the criteria is here's the evisceration of abdominal contents, just like our patient. And in this study, they say that in most of the cases it was beneficial to the patient, but it's really a two-way thing here, because if you cannot overuse this, because you are probably going to spend too much of the resources in some patients that don't actually need it. So it's actually you have to get better at triaging the patients who needs to go directly to the OR and who can go to the trauma bay and start the resuscitation there. And also I wanted to bring another study, this systematic review with meta-analysis from 2021. about massive transfusion protocol. And in this study, they found that probably the most appropriate ratio for massive transfusion protocol is 1 to 1 to 1, considering some outcomes as mortality in 24 hours and also as outpatients. And the second learning point that I was really interested is that we often see that injuries to the colon are normally, and nowadays they are treated using sutures without, or if you use resections, you can do primary anastomosis. And also in this practice management guideline, they state that if you have to resect and the patient is going for a damage control surgery, you could just leave the colon stapled, and in the second operation you just do an anastomosis of both parts. So this is really interesting, and there's still role for some situations you do a colostomy, and that's what the attendees in this case did. They thought that the best option was resection and colostomy in the same situation. The third learning point is that it was really a new thing for me, because I'm not very used to do this partial nephrectomies and to see this, but it is possible in some selected patients, as Dr. Hochman said as well. And this is a very interesting study from JAMA Surgery 2010. They discuss a lot of complications following renal trauma, and they state also in this series that they have more than 200 severe cases of kidney injury, and almost 10% underwent a partial nephrectomy. And they say that the results are really good in terms of complications. And the last learning point was about using mesh as adjunct to midline closures, especially, and also in this case encompassing the transverse incision as well. I brought a study that our group published it in 2020 in the Journal of American College of Surgeons. It was a prospective randomized trial about using mesh as a prophylactic strategy to lower the incidence of eviscerations in the post-operative period of emergency laparotomies. And also our abdominal wall group is very interested in the subject of using mesh in contaminated fields. The group has a lot of publications in this subject, and they are getting good results using the polypropylene mesh in these situations. Of course, it's controversial, and you have to select the patients that you're going to use, but it seems that the results are really good in a lot of the patients, and we've been practicing this for quite a long time as now. So the last question that I'm going to ask, and it's already open in the Socrative student, if you guys can answer this. So what, in your opinion, what was the most intriguing lesson for us in this case? So number one, letter A, is no more mowing the lawn for me. That's for sure. For me, I would go for letter A. And also, there's still room for colostomy in colon injuries, or partial nephrectomies used in selected cases, or even if mesh can be used in non-elective situations. And I'll be happy to hear the thoughts now of the panelists, the final thoughts of the case, and any comments that you wanted to address. Thank you very much.
Thank you. Domino, we have a question. Dr. Kobe has a question on our chat. Dr. Kobe, okay. Would you tell us how to close the renal edge in this partial nephrectomy?
Yeah, sure. So what they did is that they used vicryl sutures. They didn't use the ones that Dr. Hochman told us, but they put a hemostatic agent, Surgicel, over the edge of the nephrectomy, and they did sutures using vicryl of the partial nephrectomy edge.
Thank you. So, Dr. Kassim, do you have any comment, any final comment, please?
I thought this was a fabulous case, the way you managed everything. I really learned a lot from your last 5 minutes of this dissertation, how you try to educate us. I think the lesson to learn here is when you have a foreign body trauma to your torso, I think it is wise to get an X-ray. and because you don't want to be surprised afterwards. But and the second thing is, I think you have to teach your resuscitation people not to give so much fluid.
Yeah.
But the way you managed everything was very exemplary, and I learned a lot of good stuff from you today. Thank you.
Thank you very much.
Dr. Hockman, would you like to make a final comment, please?
No, I second what Dr. Kasim just said. These cases are fantastic. Very, very unusual case. I didn't even know that this type of, here they use that to do the edges of the field, but they have nylon, big thick nylon kind of, and I never saw one with the blades. I was totally surprised that that can be used that way. I think it's extremely dangerous. I guess that maybe that's the reason I don't see it here. Maybe it's not legal in the state where I am to use those to cut the grass. But this was really kind of very, very interesting case. Very well managed. Congratulations.
Thank you, Dr. Antrak. Sorry, Dr. Hockman. Dr. Antrak, any comment?
Yes, I think, yeah, I think the real lesson, the safety lesson, is don't use any power tools that don't have effective guards on the blades. I had a case that I presented at this conference where somebody was cutting aluminum extrusions using a carborundum blade without the blade guard, and it fractured, flew across the room, flew up and sliced his neck down to the internal jugular vein, half inch to the left, and it would have severed his trachea and the carotid, and it would have been still salvageable, but much more of a mess. But anyway, very interesting case, and a lot of several problems in several areas that you dealt with very well. About the stricture, where was the stricture, and how did the urologist find it? Did he just do a ureteroscopy as part of his evaluation, or and then also it looks like there was a drain, a Jackson Pratt drain that I saw exiting the left lower quadrant that might have been in the renal bed. So if that was the case, it wasn't very effective in evacuating the urinoma in this case. So even though you anticipated a possible leak, it didn't work very well.
Exactly. Yeah, very well observed. I didn't touch in the drain situation because of the time, but it seems that the drain was dislodged. It wasn't in the correct position, so it was not draining the urinoma as well as it should. And what about the ureter, it was actually something that the radiology guys saw in the CT scan. It was really, really difficult for us to see that because after the partial nephrectomy, where the ureter is going down, it was a little bit blurred, and after some time it disappeared. So you only had the contrast in the right ureter. So that's why they thought that was a stenosis, but they didn't do any ureteroscopy, not anything like that. And there was no difficulty doing performing the double J placement. So we actually are not sure actually what happened, but the thing is that it worked. Eventually the double J worked, and the urinoma just drained out without any percutaneous drainage. Yeah, and I just wanted to make clear that this is a very interesting case, of course, and I really want also to congratulate my colleagues, because I was not directly involved in this situation, only in one of the operations, but I also agree that they did a fantastic job.
Thank you, Dr. Menegozzo, for the excellent presentation. Thank you for all the panelists for the great comments. We are always learning with you. I hope to see you on next week. Thank you.
Do you have the code?
Yes.
Oh yeah, the code, right? Yes. We got to get paid.
Yeah. Of course. If you need any assistance with the code, I can send to your email too, okay?
Where is the
Please do,
code?
please
Where is
do.
the code?
The first one.
Where is the code?
In the chat.
39, yes, in the chat. I put in
Where-
this,
Oh, 13947.
exactly.
Yeah.
If you need
Okay,
some,
113.
please let me know. I can send to your email, okay?
Okay, thank you.
Thank you. Thanks a lot, everyone.
Thank you.
Bye.
Thank you. Bye-bye.